Hi, this is Dr. Shweek Chima. We will be talking about prevention of kidney transplant rejection in year 2022. I'm professor of nephrology at Allama Iqbal Medical College. I have done a fellowship in transplant nephrology at Westchester Medical Center, Valhalla in 2004. After completing my nephrology fellowship at St. Luke's Roosevelt Hospital Center, this lecture is for everyone who is involved in taking care of patient with kidney transplant, who is involved with the workup as well as follow-up. It could be a nephrology fellows, practicing physician, urologist, nephrologist, transplant physician. So the outline of our presentation would be, we will talk about what are the risk factors for acute allograft rejection, briefly review the treatment option, and then we will talk about what could be the possible preventive strategies to prevent acute rejection, and are there any newer ways to early detect and prevent acute rejection, and what is our take-home message. So it's very important to know what are the risk factors of acute rejection, because one acute rejection will lead to a subsequent rejection and then chronic allograft nephropathy that would lead to poor graft as well as patient survival. And studies have shown that certain factors affect short-term survival of allograft, including delayed graft function. And there is some data that it has been associated with increased risk of rejection as well. Preformed HLA antibodies increase graft loss 6% versus 3% at 1 year if these are preformed. But if there is a de novo production of antibody, the graft loss is even higher. We all know living related renal transplant do better as compared to diseased donor kidney transplant, and they do better as compared to expanded criteria donor, which is currently defined as KDPI of more than 85%. Some centers have better outcome, maybe based on their experience or induction or maintenance therapies. Increasing donor age is a risk factor for graft rejection. Young recipient age is also a risk factor. Donor illnesses like stroke victims, which are included in KDPI, in the disease donor kidney transplant program, is also a risk factor. ABO incompatibility as well as positive B cell cross match is also a risk factor for acute rejection. And any time spent on dialysis makes graft survival poor as compared to preemptive transplantation. And USRDS data have shown that, in which they compared almost 3,000 preemptive versus almost 10,000 non-preemptive, and the patient survival at five year 5 years based on the Kaplan-Meier survival curve is better, as well as the graft survival superior in the preemptive group as compared to non-preemptive group at 5 years at least. So I push for preemptive kidney transplantation, especially in Pakistan, where the dialysis quality is poor. Once you go to dialysis center, you end up getting a poor quality dialysis, contracting hepatitis B and C in some cases, getting less erythropoietin and IVR, and getting more blood transfusion and hence being sensitized, and that would affect your graft survival. So preemptive transplantation is the way to go. I said we will talk about briefly on kidney donor risk index, which leads to calculation of KDPI. It's a numerical number indicating the quality of donor kidney as compared to surviving uh, kidneys. Um, so there are certain factors which affect on the long term. Just one quick thing about KDPI. There are certain factors which are taking into account, like age, height of the patient, their serum creatinine, their cause of death, their hepatitis C status. So these are all criteria which were included in expanded criteria donor before, but now they're given a numerical number. Basically, it indicates the quality of the donor kidney. So certain factors affecting the long-term graft survival, including episodes of acute rejection leading to more chronic allograft nephropathy, HLA matching or mismatching. Any mismatch increases the risk and decreases the long-term survival. Sensitization either through pregnancy, blood transfusion, Recurrent repeat transplants lead to high panel reactive antibody, high donor specific antibody, which causes more rejection and also increases graft loss. Drug non-compliance and minimization intentionally or unintentionally leads to increased graft loss and rejection. People with underlying type 2 diabetes, hypertension, hyperlipidemia are at a high risk. Type of donor, expanded criteria donor, disease donor do poorly, young recipient do poorly, steroid minimization could also have a bad impact and higher rate of rejection, especially if no induction was used. So let's briefly discuss the treatment of T cell mediated rejection and antibody mediated rejection. Overall, the response to antibody mediated rejection is poor, and we had already seen that. Still, there are around 10% rejection happening in the first year, and 20 to 30% end up losing the kidney if antibody mediated rejection is not treated successfully. Even though antibody mediated rejections treatment aims at removing existing antibodies and decreasing the production of a redevelopment of the antibodies. But it's challenging and outcomes are usually poor because the treatment is unclear and there have been no large randomized controlled trial comparing the safety and efficacy of different therapeutic strategies. T cell mediated rejection is easy to treat. If you have a mild rejection, you give steroid recycler pulse. For a severe rejection, 1B and above, you give thymoglobulin along with steroid pulse. And then you augment uh, their maintenance immunosuppressants after treating. Many times I had seen nephrologists and urologists, they treat rejection, but they don't augment their maintenance immunosuppressive regimen. It is recommended if they're on azathioprine to switch it to MMF to increase the dose, add steroid if they have not been on steroid, and change cyclosporin to tacrolimus after an episode of rejection. For antibody-mediated rejection, we had already discussed there is a certain criteria you fulfill. And currently, standard therapy is plasma exchanges along with IVIG, with or without rituximab. If that does not work, you could use bortezomib, eculizumab. There are many other therapies available. There is some role of thymoglobulin in plasma cell-rich antibody-mediated rejection. But after each rejection, you augment the therapy and then you follow the donor specific antibodies periodically to early detect any future rejection. Newer therapies, in addition to steroids and thymoglobulin and rituximab and IVIG and plasmapheresis, have been bortezomib and eculizumab, and there is some data showing good results. But I always consider prevention is better than cure because it's very easy to prevent rejection following these strategies as opposed to treating rejection. So these are my top 11 strategies to prevent transplant rejection, uh, especially in disease donor kidney program. If you have preformed antibodies or it's a sensitized recipient with high PRA, uh, one option would be to avoid kidney transplant altogether, but that's not been recommended because uh, people who stay on dialysis, their short-term and long-term survival is poor as compared to transplant, even in the highly sensitized individual with high panel reactive antibodies. So what are our options if we must undergo kidney transplant? The best option would be paired kidney donation program. uh, if that's not a possibility, then in HLA incompatible individual, HLA desensitization, since these are high risk individual, then induction following desensitization, and then closely monitoring their donor specific antibodies and performing protocol biopsies for early detection. Uh, Kidney pair donation is not only for ABO incompatible donor recipient pair, but it could be done in the chain in which donor A gives to recipient B, donor B gives to recipient C, donor C gives to recipient D, and donor D gives to recipient E, and donor E back to A. So it could be done in chain. The idea is to overcome ABO and HLA incompatibility. Uh, for a better donor kidney pair with a better outcome. um, Different registries, including National Kidney Registry, when almost 3,400 patients were compared with the living donor, around 75,000, the outcome was similar. In fact, slightly better graft survival at 1 year, at 3 years, as well as at 5 years. So kidney pair donation is successful. The results are very good, probably better than even living donors. Same is true for mortality. Mortality is better at 1, 3, and 5 years in a National Kidney Registry of KDP program. The second option would be HLA desensitization. If you don't have kidney pair donation program available or donor available, and there are different protocol people are using. Anybody with the CPRA of more than 30% are seeking transplantation is considered sensitized. And the next question you would be asking if they have living donor available. If they do have living donor available, then you will perform virtual cross match, CDC and flow cross match, and assess their HLA compatibility. In case of positive CDC cross match, you evaluate other potential donor or uh, kidney pair donation. In case of negative CDC cross match and positive flow cross match, you see what is the intensity or strength, the medial channel shift. If it's less than 250, you desensitize the individual with IVIG and rituximab, and then you see if the cross match is acceptable. If acceptable, you continue with the transplantation. In case you have both negative, that doesn't mean you don't have any donor specific antibody. You could still, these people need to be desensitized because they're looking for second transplant or they have high uh, CPRA, and you continue that unless there is an acceptable cross match, and then you could proceed with the transplantation. The best would be to avoid sensitization throughout their lifespan, avoiding blood transfusion, good HLA matching, identifying different antibodies, kidney pair donation program, desensitization if they're on waiting list and they're going to get a transplant within a year, peri-transplant desensitization. And once these people end up having transplant, close monitoring of the donor specific antibodies, protocol biopsies, and screen for non-adherence. The significance of forming de novo antibodies, because once the level starts appearing up or rising, you do kidney biopsy and you could identify subclinical injury or rejection, which is basically histological manifestation of clinical disorder, because clinical dysfunction appears quite late. By that time, damage would have been done. So the same is the idea behind protocol biopsy. You identify early, the treatment becomes easy, and it's easier to treat rejection. That's why many centers have protocol to follow donor-specific antibody levels. Uh, if someone have production of de novo donor-specific antibody, meaning they didn't had the antibodies before, but they started developing it afterward, this is the case scenario in most of our patients who get living related renal transplant with 1 or 2 or 3 mismatches, or decreased immunosuppressants, the two most significant factors which cause the production of de novo donor specific antibodies, medication non-adherence, or inadequate immunosuppression. Basically, inadequate immunosuppression that also stems from medication non-adherence, or if you're using non-tacrolimus based regimen, or if you're not giving induction in people who have even one HLA mismatch, or you're giving tacrolimus and induction, but you're keeping low target of tacrolimus, and then also non-linear creatinine and GFR relationship is not well understood. So all these factors, if you take care of these, there would be less production of de novo antibodies and less rejection. And these are my next 6 targets. So let's discuss them one by one. Let me discuss a small case. This is a real case. This is one of the patient referred to me almost 6 months after a transplant, 3 antigen match kidney. Creatinine was 1. He was on delta cottle 5, MMF 500 BD, cyclosporin 100 BD. and C0 258 and C2 712, which is a decent level. No induction was given. Apparently, nothing seems wrong with this patient. He's creatinine 1, he's doing great. But we end up biopsying this patient, and I'll tell you why we found marked IFTA and antibody-mediated rejection with C4D positivity. We didn't end up checking the donor-specific antibody, but the reason we biopsied this patient, even though he was referred to us, and if we would have looked at the creatinine of 1, we would have been happy. But he had creatinine, the lowest creatinine was 0.6 4 months ago, 2 months after transplant, and then it increased to 0.8. So if you see what is the change in GFR from zero point 0.6 to 1, the fall in GFR is almost 40. So 40 fall in GFR, don't you think there is something wrong with the kidney, or you should be doing biopsy? Because many people don't understand the relationship, the non-linear relationship. At early stages, when your kidney functions are preserved, even slight increase in creatinine lead to almost GFR drop of 51. The same increase in creatinine in advanced kidney diseases lead to GFR fall of only 4. So early on, a slight rise in creatinine have a huge impact on GFR, and we need to understand this concept. The way we were trained during our fellowship, if your creatinine goes from 1 to 2, you have lost your 50% kidney function or GFR. So then many centers are still using cyclosporin, which is a wrong approach. Cyclosporin is out of favor. Cyclosporin do poorly as compared to tacrolimus in terms of graft survival. The rejections were 14% in tacrolimus group as opposed to 24%. 3 and 5 year graft survival is poor. Nobody uses cyclosporin in the US anymore. In 2012, 99.5% program were using tacrolimus-based regimen. Only 0.5%. They must have been in trial or something. If you look at all the maintenance immunosuppression trials and the outcome with the least number of rejections, 7, 9, 12, they are the one using tacrolimus-based regimen. With induction, with 1 gram twice a day or 1.5 gram twice a day of MMF. So you need to use a good dose of MMF, anti-proliferative. You need to use steroid. You need to give induction. You need to keep level of tacrolimus little bit above 4 or 5, because there is a data. These are 4 randomized controlled trial involving almost 528 patients using tacrolimus uh, and induction in most of the cases. And all of these showed if your level of tacrolimus is less than 4, the cumulative hazard ratio or the graft survival is poor as compared to if the level of tacrolimus is more than 4. So low tacrolimus level has been associated with increased risk of rejection. But most interestingly, all of these patients were given induction, and we don't even give induction. If you don't give induction and you're trying to keep level around 5, uh, that would increase the risk of rejection. I would like to keep it maybe around 6 and above. Let's talk about induction. Induction has been recommended by KDOKI, KDIGO for all live-related renal transplant. Different randomized controlled trial using ATG showed superior outcome. Alemtezumab meta-analysis of 10 randomized controlled trials showed it superior, and there is less rejection if you use this NTCD52 monoclonal antibody, and same is the case with rituximab. So currently the recommendation is, unless you have a 2 haplotype match identical living related donor, or you had already had 1 organ transplant, you don't need reduction. All other case scenario need reduction. In our live related renal transplant, 1 or more HLA mismatches is common, and it's present probably in more than 90% of the patient. And most of our recipients are younger too. So these two alone are enough. And if you have a calculated PRF more than 20%, DSA, cold ischemia time more than 24 hours. If you have any one of these, you need thymoglobulin or ATG. If you have none of these, you still need induction because you don't fall in this category. But you could get away with basiliximab or low dose thymoglobulin. People have been looking for different biomarkers, and in fact, we did a study in 2004 at Westchester Medical Center, Valhalla, uh, with Dr. Khalid Bhatt, Veronica Delaney, and this is me, in which we would be checking for urinary proteome for acute allograft rejection. I still remember anybody who would have rejection, I would have to take urine to a lab, and they will be checking for different urinary peptide to see if it correlates with the rejection. The studies are still going on. Even in 2022, people have been trying to look for protein biomarker, but none of them have made it to clinical practice yet. But what made to the clinical practice at this point is donor-derived cell-free DNA. So these are the DNA present in the recipient blood, and from the SNP differences, you could tell this is donor versus recipient DNA. Normally, it's not present in a great number in the recipient blood, but in case of active rejection, you would see more of the donor-derived DNA, and Prospera is a transplant assessment in which they check this. Uh, there is a huge study done in which 107 kidney biopsy results were compared with different levels of donor-derived cell-free DNA, and the level of 1% have been determined, and the p-value with different elements is given here. So at 1%, the p-value is significant for antibody-mediated rejection, meaning you have a significant relationship. Higher the donor-derived cell-free DNA in the serum, more would be the antibody-mediated rejection. Same is true with linear C4D staining, donor-specific antibodies, so on and so forth. So this has become the standard of care for early detection in USA. Not only it determined the rejection and graft survival, but there are so many other benefits associated with it. It's exactly a fragmented DNA that is continuously shed into the bloodstream from the allograft undergoing injury. Its half-life is very short. Several assays in USA are available. In one study in which they used more than 1,000 patients and checked their donor-derived cell-free DNA level, they found out that level of more than 0.5% was associated with threefold increased risk of uh, developing de novo donor-specific antibody, and level more than 1% was significantly associated with rejection. Persistently elevated level were associated with decline in GFR. I was talking to one of my friends who's a director of a transplant program, and they said they have a protocol in which now for all of their patients, they're checking it at month 1, 2, 3, 6, 9, 12, and then every 6 months for the life of the graft. So based on the discussion, our take home would be to avoid sensitization and blood transfusions, follow KDIGO recommendation for induction, and use induction in all except 6 HLA match kidney transplant recipients. Consider referral to nephrologist as early as possible, and the nephrology team should be on board throughout. Consider donor-specific antibody monitoring and protocol biopsies. And for that, if we could make donor-specific antibody monitoring more economical so that we could follow up closely, educate about adherence to immunosuppressants, optimal immunosuppression, utilizing tacrolimus-based regimen, and then augmentation of immunosuppression after each rejection. And then we really need to work on development of kidney plate donation and to promote that program. And donor-derived cell-free DNA monitoring when available would be very useful. And CME activities in which we spread awareness of early detection and prevention would help a lot. That's all about rejection of the kidney transplant and how we could prevent it. Prevention is always better than cure. I hope you like it. Thank you very much.